Thank you very much. It's great pleasure to be here today with you. And what I would like to do is to update you on the current use of cryotherapy in kidney cancer. Here is the outline of my talk. As you may know, renal cell carcinoma accounts for approximately 3% of adult malignancies, and it comprises more than 90% of kidney neoplasm. This tumor lacks early warning signs, it has diverse clinical manifestations, and it is resistant to both radio and chemotherapy. Increasingly, RCCs are diagnosed at an earlier stage, and nephron-sparing surgery, as well as ablative techniques, are gaining more acceptance as the treatment of choice for small renal tumors. The widespread use of non-invasive imaging modalities such as ultrasound, CT, and MRI is responsible for the increase in the incidence of this tumor. Most of the increase in renal cancer, as you can see on the left side, is due to localized disease. And indeed, at time of diagnosis, nearly 2/3 of the patient will have localized kidney cancer. About half of the patient have stage T1A. That means their tumor is 4 centimeters or less. The increase is also mainly to elderly patients, and when we detect the kidney cancer, about half of the patients are 65 years or older. So in 2019, the typical patient with kidney cancer is a male. He is over the age of 65. He probably has some comorbidities. His tumor is less than 4 centimeters, confined to the kidney, and of low grade. Most of them are small tumors. This slide demonstrates options for treating small renal tumor. And as you may see, there is dramatic change throughout the years in the mode of therapy. While in the past, we used to do radical nephrectomy, that means to remove the whole kidney for any size of kidney tumor, we later on realized that if we just take the tumor, we do partial nephrectomy or nephron-sparing surgery, we get equally effective treatment, but with the advantage of preserving kidney function. We later on moved to thermal ablation, and today we are also willing to treat patients by just observing them. But this talk will focus on the thermal ablation and specifically on cryoablation. Now, when the patient is coming with a small renal tumor, what are his perspectives from this cancer? Well, he would like to avoid dying from the cancer. He would like to avoid pain and complication, to preserve maximal renal function, to reduce length of stay in the hospital, to reduce cost, and to get the maximal cosmetic results. So when this patient with his tumor comes to the urologist has so many choices, which one to choose? And cryoablation is really an optimal way to treat many of these patients. Cryoablation in the area of kidney cancer is not new. It is more than 20 years since the first publication of percutaneous and laparoscopic cryoablation. Since then, this technology, this technique, have spread into the medical community, and this slide nicely demonstrates the diffusion of this technology. This slide demonstrates the number of publications per year, and you can see that is steadily increasing, indicating that the community, medical community, is happy with this technique. The standard way to do ablation of kidney tumor is by cryoablation. And you have heard it might be done with liquid nitrogen, as we do, or it can be done with argon gas. And the other option is heating mainly by radiofrequency, but you should know that there are emerging technologies that are already in use in Center of Excellence, microwave ablation, Haifa, high-focused ultrasound, irreversible electroporation, and stereotactic ablative radiotherapy. So, this technology, we ask ourselves, what is the place of cryoablation in treating renal cancer among the whole therapeutic option? And this study is a nice study, not very big, 600 patients, looked only at patients with tumors 4 centimeters and less. Patients were treated by radical nephrectomy, partial nephrectomy, ablation, and active surveillance. And they were compared in 3 domains: oncological, functional, and quality of life. And here are the results. The oncological outcome, as you see on the left, the cancer-specific survival was virtually the same in all treatment arms. However, the overall survival demonstrates inferiority of the active surveillance group. This is probably due to the baseline health status that was the reason for choosing active surveillance. What about renal function? As expected, the group that underwent radical nephrectomy did worse compared with the other. And what about the quality of life? Again, the active surveillance group did worse, reflecting their baseline health status. This is another study, a bit larger, nearly 1,800 patients coming from the Mayo Clinic. But this time, the comparison was done not only for T1A patient, but for T1 patient. That means the tumor could be up to 7 centimeters. And when they analyze only the T1A patient, that means patient with tumor up to 4 centimeters, you see virtually the same results across all treatment group. And these are the numbers, very impressive. However, this was not the case when the T1B group was considered. Patients having tumors 4 to 7 centimeters, as you see on the right side, the cancer-specific survival of the cryo group was less effective. And in numbers, they had 7% less 5-year cancer-specific survival. So this gives you an indication that the issue of size is important in selecting patients for treatment. And here is a study that assessed this issue. Look at the title, Impact of Tumor Size on Cancer-Specific Mortality Rate After Local Tumor Ablation. This study, nearly 4,000 patients, and they were divided into patients with tumor up to 3 centimeters and those with tumor more than 3 centimeters. Look at the left, the 5-year cancer-specific mortality was more than 3-fold higher among the larger tumor. So today, in 2019, we know that the size matters. When you counsel the patient, you have to use it. Another issue that was not clarified until recently, what is the exact role of cryoablation in treating renal tumor? Well, here is a study coming from the European Registry for Renal Cryoablation, 8 institutions, 800 patients, and what emerged, what comes is high rate of complication. Not only this, look at the results. And if you compare them few slides before to the Mayo Clinic results, you see here the laparoscopic oncological outcome was not as good. And I would like to bring you the editorial to this manuscript. Look at the title, Laparoscopic Renal Mass Cryoablation, an operation in search of indication. They said, what is the indication? And what they said practically is that if you are there with the lap instrument, take the tumor out. Why start with the freezing when you can do it percutaneously, get at least the same oncological outcome, but with significantly less complication? Another issue in these days is how to reduce the radiation dose exposure. And this study that incorporates ultrasound demonstrate that you can do it. We are also considering such study. The place of ultrasound is both for placement of the probe and also for monitoring the ice ball. In 2019, we are more willing to use predictive tools. Look at this 73-year-old male with 3 centimeter enhancing solid renal mass. When you use the Fox-Chase nomogram, you find that the probability that this gentleman has high-grade renal cancer is 20%. This can be helpful to you. And what are the chances that this gentleman will have 5-year cancer-specific mortality? Only 3%, as you see here. Only 3%. You can use it when you count. Now, we are not anymore treating the classical lesions. You see small posterior peripheral lesion. This is what we did in the past. But today, we're willing to get some more challenging cases. Look at the left. This is ablation of RCC in transplant kidney. Look at the middle. The tumor size, which is completely endophytic, was relatively large. So pre-treatment embolization reduced the size and enable perfect freezing. We are also willing to treat small hilar tumor, as you see in the right. Unlike in the past, look at the left side, you see the renal mass approaching the liver. But Robert, our interventional radiologist, is not afraid from the liver. You see in the middle, the probe is crossing the liver, and this is the freezing. On the right, you can see the ice ball demonstrating that this was a perfect procedure. We're still not doing everything. Don't get me wrong. This is a large hilar tumor on the left. This we shall not treat by cryo. On the right, you can see a tumor that penetrates into the sinus fat. This is also not adequate for this. What about the guidelines? Well, this is the European guideline, 2019. They recommend radiofrequency ablation and cryoablation for elderly patients or patients with comorbidities with small renal mass. And this is the NCCN guideline. As you see, this is 3 months ago, June. And this is different from the previous version. Why it is different? Because here, for treating T1A patient, ablation is now the second recommended option by the NCCN guideline. This was not in the past. So, in summary, cryoablation for renal tumor is feasible, it is safe, effective, low complication rate, it is cost effective, and it can be repeated easily. Let me add something else which I saw in the first movie, the 16 millimeter black and white. It is quick. It is quick. And let me tell you from my experience, we do a lot of surgery, but when we do the cryoablation in the morning as first procedure, at noontime the patient are running to eat. And if they are doing surgery, they still don't understand that they are after the surgery. Well, this brings my talk to its end, and I would like to thank you for your kind attention.